Oh, oh, okay, so this is urine cytology specimen, and it was sampled from the left renal pelvis, so it is an instrumented urine. 有吗？ So in this specimen, we have a lot of cell. It is as expected because it's from instrumented. And you see a lot of single cells, and this is what we like to see because it's easier to evaluate the cytomorphologic features. So in this specimen, you see a lot of single cells with very high NC ratio. The cytoplasm is only like very scant and rimming around the nucleus. And if you go to the nuclear features, it shows a little bit hypochromasia, right? So this is also a diagnostic feature, and it is more common for the instrumented urine because it has good fixation. So it is not degenerated. It is well fixed because all these cells are like freshly flushing from the epithelium. So you see hypochromasia, but you still see there are scattered area with these clump chromatin pattern, like coarse, very clump chromatin pattern. Okay, so this is diagnostic for high-grade uveocellular carcinoma. We will usually be more cautious for the upper tract urine cytology specimen because the subsequent management could be really really destructive because it usually involves a radical like a nephrectomy and a ureterectomy. But in this specimen, I think we are very confident that it is a high-grade urothelial carcinoma. So here you see a cellular fragment, and you also see mitosis over here, right? Okay, so this is positive for high-grade urothelial carcinoma. So next is a pleural effusion from a 65-year-old female. She is a new patient. So the clinical scenario is common, middle-aged Eastern Asian woman, non-smoker, and with like a dyspnea and pleural effusion. And you check the pleural effusion and you see this is adenocarcinoma. So this has become the most common cancer now in Taiwan, probably the other Asian country as well. And this would be usually the first diagnostic specimen, and we will do a TTF1 on the cell block preparation. So in the cell block, there are still quite a lot of tumor cells. So the next specimen is a 33-year-old female. And this is her pleural effusion. So the patient had two different history. One is rectal adenocarcinoma. The other is breast invasive carcinoma. So it has become very common that we will see the patient have two cancer, even three cancer nowadays. And sometimes we need to decide where is this coming from. So by morphological feature, I think breast is likely, especially the breast is also from above diaphragm. It is organ from upper body. And the rectum cancer is usually more necrotic, and it's from below the diaphragm. So here we see cluster of carcinoma cells with very prominent nucleoli, vesicular chromatin. The cell arrangement, they would be like loosely cohesive. There is no very prominent like a cell ball, but here you can see this could be like a cell ball, cannonball pattern. Right here is also. But the other thing is that some of the cells do have like elongated nucleus. So I guess in this specimen we would need to do immunohistochemistry to check. And here it seems to be more like a tall columnar. This looks more like intestinal type, right? And with some like a chararesis inside the glandular structure. So I would say the cytology and probably these could be a breast, but this also looks like colon, and it would be really difficult just to make judgment by morphology alone. So I guess in this specimen, we really need immunohistochemistry to tell the clinician where is this coming from. And from here, you're starting to see feature more definite for rectal adenocarcinoma over here, right? Because this is very dirty necrotic pattern. Yeah. So this specimen, we still need to do immunohistochemistry. I think this is from the same patient. Okay, so the patient has a past history of lung cancer, and we were looking for evidence of recurrence. And sometimes for the recurrence, like effusion, the cancer cell might be very, very scant. So it would sometimes be a little bit difficult. But here you see this is a lymphocyte. This could be a histiocyte or mesothelial cell. And these two cells looks a little bit strange. Its nuclear size is enlarged comparing to the adjacent normal cell. The cytoplasm is very scant. The chromatin pattern is coarse. And you can see the shape of the nucleus is a little bit strange, and they were vague like a nucleoli inside this nucleus. So these two looks very suspicious. So we want to see if we can find some more like a typical cell that we will feel more confident to call it carcinoma. And because in this specimen, the background shows some proteinaceous like materials, so the cells can be stuck inside this material. So here you see a very large nucleus, prominent nucleoli, eccentric like a pattern. So these also looks like adenocarcinoma comparing to the adjacent benign cells. So in this case, they were very scant, very suspicious cells. So then we move to the cell block, and here we have some more definite like cluster of the cell and with artificial like cleaving. So this is more definite for adenocarcinoma. And here as well. Yeah, so in this specimen, we call it adenocarcinoma. It's compatible with recurrent disease. The next specimen is also the patient of primary lung adenocarcinoma and rule out recurrence. So in this specimen, is more prominent, like tons of tumor cells. And most of the cells have kind of similar morphologic feature than the specimen that we just see. So these are single cell mostly, some with eccentric nucleus. And the nuclear atypia is very prominent. So you can see hyperchromasia, vesicular chromatin pattern, variation of the size of the nucleus. The nucleoli is not very prominent, but you can see scattered cells with very prominent nucleoli. So this is positive for recurrent disease. So the next specimen is from a lymph node aspiration in the neck. The patient had a past history of breast invasive ductal carcinoma. In this lymph node aspiration, in the background, we didn't see a lot of lymphocyte. So this is the first unusual thing. The second is that we see most of the cells are in cluster in the epithelial arrangement. So this is also not normal for lymph node aspiration. And here we see like three-dimensional epithelial cluster and in a cell ball pattern. And here we see more like increased NC ratio. And here as well. So this is positive for metastatic carcinoma. And given the patient's past history, the breast carcinoma is compatible. The next specimen is a breast aspiration specimen. I would say the breast lesion for the aspiration is not very common. Nowadays, we more commonly receive core needle biopsy. But in some, like our branch hospital, they still like to do that. So here in the background, you see some like a cystic degeneration, and we see a lot of cells in like a tight cohesive fragment. So when we see tight cohesive fragment, we feel like it's mostly benign. And in the background, you see the single cell, they have this ovoid shape, some with elongation. These are all male epithelial cells. Very commonly, they will show naked nucleus. So you have the mixture of ductal cell with good cohesion and male epithelial cell. So this is likely a benign lesion. And with also a cystic background, it is most commonly to be a papillary lesion. So for a papillary lesion, sometimes you need to be very cautious, because they could be like in situ lesion in the papillary lesion, and they also could be papillary carcinoma, but still in situ. Yeah, the classification is sometimes a little bit complicated. So here you find this could be more like a superficial lining, more contact with the cystic lumen, but so there could be some change in size of the nucleus. But here you definitely see there are some atypical changes of the cell, the nucleus. So I would say the case we have small focus of atypia, epithelial atypia, and the majority, like this is very good for benign papilloma. Looks like this, okay? But they are indeed scattered like skin cells with nuclear atypia, prominent nucleoli, and the variation of nuclear size, right? So these could be cystic change, but these could also be just sign of in situ. Yeah. So for this case, it's better just to call it atypical, not benign, because you indeed find some atypical cells. Okay, so papillary lesion is tricky, and it's better to have a biopsy confirmation. So the case was diagnosed as a typical papillary lesion with focal atypia. So the screener need to pay attention to scattered like atypical cell and to pick them up. The next specimen is from a thyroid aspiration, and it is also from our branch hospital. So there is no liquid base like a preparation. So on low power in the background, we didn't see colloid. So first thing is that the colloid is very scant, but we still see some cellular fragment, some with large fragment, and you can appreciate there are a lot of stromal cell inside. Some may be vasculature, like vascular structure. So here we see a stromal fragment and some follicular cell like attaching to these stroma. And here we see the cellular cytology feature with more abundant cytoplasm, and the cytoplasm is very granular. So this looks like oncocyte or Hurso cell. And if you go through the entire specimen, you can see tiny cellular cluster like these throughout the entire smear. And when you go on higher power, these tiny like a cluster looks like a microfollicular pattern, right? Here, here, and here. So this case is a very good case for Hurso cell tumor. Okay, so this is suspicious for Hurso cell tumor. You see microfollicles of Hurso cells. Majority of the cellular component are all Hurso cell, more than 90%. You see prominent vascular structure because most of the Hurso cell tumor are very vascular. So sometimes you will see a lot of this vasculature, okay? And you see these very tight, dense type of colloid. This is also the most common colloid pattern that we will see within the microfollicle of a Hurso cell tumor. Usually that would be really dense. Sometimes there would be even pseudomonas calcification. Okay, so this is a typical case for Hurso cell tumor. It is not very common that we make this diagnosis. So for this case, we call it TBS4, suspicious for follicular neoplasm oncocytic type. Okay. So then we move to a correlation case, the case that we have reported yesterday in the annual cytology meeting by one of our cytotech. The patient is a 37-year-old female, and she had a thyroid nodule, and she received fundal aspiration. So this is a specimen that we can see right next to the other specimen that we just see, the Hurso cell specimen. So on low power, you still see there is no colloid in the background, right? And the cellular component looks like Hurso cell, right? It has more abundant cytoplasm. But we didn't see the nucleoli that we see in the other case, because usually for the Hurso cell, there would be like a small nucleoli that you will see inside the nucleus. Here we didn't see. And additionally, there were also very prominent vasculature. So you see a very prominent papillary architecture. So this is one of the most common misdiagnoses to mix papillary to mix parathyroid lesion as a Hurso cell oncocytic tumor. So this case, because of this very prominent papillary architecture, Hurso cell pattern, vasculature, and lack of any colloid, the lesion was suspected to be a parathyroid lesion instead of a primary follicular cell-derived lesion. So you can see very prominent papillary architecture. So because we don't have liquid-based specimen for this one, we do a cell transfer and we remove one of the alcohol-fixed slide. We make the stain and we stain with immunohistochemistry. So we stain is with first TTF1. This is TTF1. So the cell is negative for TTF1, but it is positive for GATA3. GATA3 is the marker of choice that we would do in the cytology specimen because it's a nuclear stain. And if we want to make distinction between follicular cell versus parathyroid cells, we would choose GATA3 and it is diffusely positive. So we diagnose this as a parathyroid lesion, and the clinician starting to check the serum calcium, serum parathyroid hormone, and it is highly elevated. It's more than 300. And then she was referred to the main hospital and to do the parathyroidectomy. So in this specimen, we find a lot of thyroid tissue with prominent chronic lymphocytic thyroiditis. So in this setting, sometimes the capsule of the thyroid could be fibrotic and attaching to adjacent structure. So here you can see the parathyroid lesion is actually tightly attached to the thyroid tissue. And something also worrisome is that we see a lot of small nodule, and the capsule is ruptured because the clinician just ruptured the capsule. And you see here is also a tight nodule, and here is also a nodule even within the thyroid stroma. So it is a little bit annoying. Yeah. So for the parathyroid lesion, sometimes it's very difficult to address the biological behavior just by pathology examination. But in this specimen, we see nodular, like a protruding inside the thyroid parenchyma. It could be because of the chronic lymphocytic thyroiditis, but I think this one is just too deep, right? This is very strange. It's just very strange. And by morphology, you can see the cells have some of the cell with polymorphism. And a lot of cells show binucleation, as well as vague nuclear halo, perinuclear halo. So because of this morphology, I highly suspect this case would be parafibromin deficient parathyroid neoplasm. So here you see more striking nuclear polymorphism. So that is very strange. And the PDH level is high. It's 300 or 400. Usually it's not that high. However, I do a parafibromin, it is still intact. So I've never seen a case with parafibromin, like a loss of nuclear expression so far. That's would be an uncommon disease. However, given the still like a nodular, like a growth inside the thyroid, I would still prefer to call this a typical parathyroid neoplasm. Okay, so in the new WHO, we have these indeterminate, like a intermediate category that we can put. It is much safer because sometimes you call this adenoma and it keep coming back. And because the patient is so young, so I think it is more appropriate that we still call these a typical parathyroid tumor instead of just a parathyroid adenoma. So the case is actually detected, make very good diagnosis by cytology first. And the clinicians start to work up the patient, find the tumor, and then it is a typical case. So finally, let's see some pap smear. So this is a relatively young patient. So we have good and intermediate cells. So if you go to the dot, you start to see like definite feature of low CO. So you see multinucleation, you see enlarged nucleus and some perinuclear halo, and some hyperchromasia comparing to the adjacent like a benign intermediate cell. So here you start to see some low CO pattern, and you go around with the same smear direction and you see more cells. And here is also very good, a good one, and you can see coarse chromatin pattern comparing to these pinpoint, like a very delicate chromatin pattern in the superficial cell, intermediate cell, and you see coarse chromatin in large nucleus and a lot of cells. So we call these low CO. So this is a low CO case, definite low CO case. The other case is a middle-aged female, and this one is also very easy because we have a lot of lesional cells. So here we see definite low CO pattern, right? We have markedly enlarged nucleus of the intermediate cell while still maintain the low NC ratio. We have some multinucleation and hyperchromasia over here. And then we have very increased high NC ratio cells with marked hyperchromasia, some of the single cell in the background. And what I want to show you is this one. This looks like some glandular feature at the periphery, and the cell is here. You see some like a flattened cells, but here you see more like glandular, like a pattern at the edges. So this looks like a glandular involvement of the high CO. Okay, so in this specimen, we have a lot of foci that looks like glandular involvement because you see these looks more like a glandular cells. But here in the middle, you cannot see through. It's very, very dark. Some of the area you see flattened squamous feature, but these are all glandular. So this is a glandular involvement of high CO. And you see high CO, and you see low CO cells. And along the smearing direction, you still see a lot of high CO cells. So in this one, we have a lot of lesional cells, and it is not, it is very difficult to miss these lesional cells. So this is a high CO. The patient, this is her very first pap smear, and she came to our hospital because she has heavy mens and seems to be like at the perimenopausal stage, so it just is like an irregular menstruation. But this is a good case that we screen, we identify high CO, and the patient now can have a curative definite treatment for the high CO lesion. Okay, so this is a very typical case of high CO, and then we also see glandular involvement. And here we have another high CO case. And this one is the cellular component is more scant, but you can still see these are definite squamous differentiation because most of the cells are at the edge are flat and it has some spindle shape. It's very hyperchromatic. So this is a very definite cluster of high CO squamous cell. And here you see some low CO pattern over here, right? So in this specimen, there are not so many single cells. Mostly are in tight cluster. So here you can still see there's a very tight cluster. In the middle, there are keratinization, but at the edges where you can see through more clearly, it's coarse chromatin, irregular nuclear like a shape, and increased NC ratio. And here as well, you can see increased NC ratio hyperchromasia, and the polarity is all like a very disorganized. Okay, so this is also a high CO case. Okay, So that's it for today.